mostly with the hospital, but he does call in doctors. So he interacts with you guys when you're doing non-emergency transportation. So that's why I wanted him here, so he could talk about challenges and opportunities he sees from his end. So, yeah, okay. So anxiety's kicking in. Just give me a second to get talking and we'll be good. Basically, what I wanted to talk to you guys about is what's hospice? It's a level of care that's provided by and covered by Medicare, Medicaid, and most insurances. It requires, yeah, you're doing that while I'm sitting here having a flash. Thanks, that helps. It requires a doctor's order and a doctor's referral to get started. We don't have to have an order to go out and talk to a patient, but we do have to have an order to start services. The focus is on care is on comfort care and quality of life. So we don't focus on dying. We're going to focus on comfort. We're going to focus on quality. We can't give you more days to your life, but we can give you more life to your days, kind of a thought. So one of the handouts that I gave you, and Eric can jump in anytime. If you guys have questions, I'm not going to wait until the end to say, okay, question, Q&A now. If you have a question, shoot it at us. Many things qualify for hospice. We have not just cancer patients. Those cancer patients are people that aren't seeking curative treatment. We all know the trajectory of cancer when you stop getting treatment. So those are appropriate for hospice. We have cardiac patients. We see end-stage ASCVD, CHF, aortic stenosis. But those people aren't a candidate for surgery. Their ejection fraction, and I don't know if you guys ever see the H&Ps on these folks, is less than 40%. Most of them that we see in hospice have 30, 35. We've got a guy, a referral we're looking at right now, he's got 10 to 15% EF. So they're end-stage cardiac patients. Some of them, they've been non-compliant all their life. That's why and those are your frequent flyers you guys are seeing. Those are the ones that you're out every other week taking them to the hospital because they ate a bucket of KFC and they're blown up like a tick on a dog. We do end-stage pulmonary, so we see pulmonary fibrosis. We see acute respiratory failure, these people that are chronic. Again, those are the people that are frequent flyers for EMS. You're there every other week because they're in a COPD exacerbation, can't breathe, and you guys are out there trying to get them comfortable and take them back. End-stage renal, they're not getting dialysis anymore. We have dementia patients, which is a lot of people are like, what are you talking about, dementia?
Or for the patients that still want to get dialysis, but they're so far progressed that they're too hard to get to and from dialysis appointments anymore.
Yeah, true.
At this point, it's like taking 3 steps backwards to go 2 steps forward. Those are the patients we're also looking for. You get out there, these patients, ooh, Mr. and Mrs. So-and-so has lost a lot of weight even in the last 2 weeks, or this last month since I've seen this patient again. And that's another thing, we've looked at diagnoses, and like, well, we don't know if there's a diagnosis. We look in there and we look at their labs, and their albumin is less than 2.5. So that's another thing, if a patient has an albumin on their labs of 2.5 or less, that qualifies for hospice care along with that weight loss, because that is what they consider now severe protein calorie malnutrition. It used to be failure to thrive. Now that is not identified per Medicare guidelines. It is now severe protein calorie malnutrition. So that's another one we're looking for. Those patients are no longer really eating or drinking much anymore. They're sleeping a lot more. You notice they can't really hold a conversation. If they do, it doesn't make much sense. All those are patients that are absolutely hospice eligible.
Mm-hmm. Yep. Yeah. Dementia patients, I gave you guys this handout, which they cut off on the side. The FAST score that's on there is what we're looking at, and most end-stage dementia patients. So the FAST score is for Alzheimer's disease specifically, not just dementia because they had senile dementia or CVA and they've had vascular dementia, specifically for Alzheimer's diagnosis. And they progress through these different stages. When they hit a FAST 7A, that's the end stage of Alzheimer's. That's where you get your people that don't smile, don't communicate, they're super confused all the time, they're incontinent. So they're appropriate. Those folks we're really watching close too because they do progress slower than other diseases. But they're totally eligible for hospice. Now, sometimes with non-cancer diagnosis, we get in there, we help manage their symptoms, and they get better and they're not appropriate for hospice anymore. So we'll graduate them off of hospice, stay in contact with them, educate the families, call us if things change, we can come out and reevaluate and get a new order if something's different. Liver failure, your hepatitis folks that have liver failure, your alcoholic and non-alcoholic cirrhosis patients that have the belly out to here. That's hospice appropriate. Neuromuscular disorders like ALS, MS, things like that, myasthenia gravis, those things are appropriate for hospice. The clincher for the doctor is that they have to say the patient has a prognosis of 6 months or less. In their best medical estimate, that's where the patient is. Does it mean all hospice patients die in 6 months? Of course it doesn't, because we don't drive that bus. Doctors make an educated guess, and then we go from there. So that being said, it's not just cancer, and that's what a lot of people think hospice is for. You have cancer, you're knocking on death's door. We want to get you when you're 6 months, 8 months out versus your chains stoking when we walk in the door, because the family misses out on a ton of education and support when the doctors refer late. And these are, like I said, these are the people you guys are going to see. They're going back and forth to the hospital. And if Eric can get in contact with these families in the hospital from his end, then we can help them live a better quality of life. And they're not always in the back of your rig.
That's why hospice gets the bad name. I've noticed that since I've been doing hospice for a little over 4 years. Is hospice gets a bad rap because hospice is always chosen too late. So then by being always chosen too late, we think that those are hospice patients only have a few days left and they're going to pass. No, it's not. It's because those families chose to not do hospice until late, or the medical PCP or whomever was over their care decided too late. That is why, like right now, we're getting so many patients that we get from the hospital. We go back and look in the notes. Wait a minute, this patient was here at the hospital 3 weeks ago, 2 weeks before that, at the PCP a week before that. Why, at any point during any of those visits, was that hospice not brought up to this family? And that's because, again, families have a bad misconception of it because it's not identified soon enough to where they can truly get all the benefits of the social worker being a part of that family, helping them plan things, being a part of the nursing coming out there to manage symptoms so they have a better quality of life. That CNA that could have probably helped that elderly spouse care for that patient a lot more hygienically, and things that could have been done and maybe kept that last hospitalization from happening. Those are all the things that we're looking for with hospice, and that's why I always like to ask. And even when I did informatives with and educations with residents and stuff, they think that we have got a couple buckets of morphine out there in the car that we're going to drive up to the house and load them out there, and that is not what hospice is at all. That we're always trying to reach and keep them comfortable without overstepping that threshold of the pain medications.
And we'll talk about meds and stuff in just a little bit. Hey, dude, thanks for stealing my thunder.
Yeah, absolutely. Anytime.
Yeah. I've been a hospice nurse for 22 years, so hospice is my heart. But yeah, what Eric said, there's a team that comprises the hospice team. It's the physician that gives the order. It's our medical directors that help manage the end-of-life care. It's the registered nurses assigned to them. We have LPNs that help manage their symptoms, communicating with the physicians, drawing labs if we need to draw labs, which we try not to do because, sticking people with needles isn't a comfort measure. But if we need labs for albumins or something, we can draw labs. And it's all done in the patient's home. We have the social workers that are their resource for community resources. They help them with legal paperwork, powers of attorney, living wills, funeral arrangements, and they provide companionship. And it's another set of hospice eyes on this family, educating them on what's going on, what we're seeing. And if we're doing our job right, we're seeing changes. Dying is like being born. The body goes through a process to bring a baby into the world. The body goes through a process to leave this world. What we see dying, our dying is different than your dying. You guys see acute and traumatic death. We see natural death, the body going through the process of the systems shutting down. They stop eating, they stop drinking, they start sleeping more. There's just a process that the body goes through, and it's normal. I always tell my families, what's normal for me is not normal for them. And my job is to teach them what I'm seeing and what I expect I'm going to see next and what they're going to do about it. So at 2 o'clock in the morning, they're not dialing 911 because mom's having apnea, because they've already been educated that they're going to see apnea. They're going to see Cheyne-Stokes breathing. They're going to see modeling, and we'll talk about that in a little bit. We have a chaplain that goes out and provides spiritual support. They provide companionship and another set of hospice eyes. We have volunteers that can go sit with them. They don't do hands-on care, but they're a warm body in the home to make sure that patient is safe while their loved one goes to the grocery store. We have volunteers that clean house and do yard work. And so there's a benefit to the family if, you know, the husband's taking care of his wife and 4 little kids, who's mowing his yard? You know, so we have volunteers that will do that. We have some soldiers, or we did have, and they're trying to build that back up, that's what they want to do. They want to do stuff like that to help people out. They're not all about being right there with the family, but let us do your yard work for you. So,
And with that, another feedback we get sometimes is, well, Eric, I don't want a lot of people coming in my house. That's fine. The great thing about hospice is they have the steering wheel as well. If they don't want a CNA, or if they want a CNA once a week, or they want a social worker to come out one time, and then if they need her again, they can call us. It's absolutely geared to the patient's needs and the family's wants.
yeah, so the only thing they have to have is a nurse. They have to see the nurse at least once every 14 days. So we usually see our people 2 to 3 times a week. If they start transitioning to the dying process, we see them every day. Somebody from the team, there's a touch from the team every day. Nurses usually 6 times a week. The social worker, they have to have a social worker, which they really don't because that's optional, but we tell them they have to have a social worker. They usually go at least once a month just to do a touch base with the family. The other services we offer are optional, chaplain, volunteer, and aid. We provide all their medications that are related to not only their diagnosis, but their prognosis. So hospice changed from diagnosis focused to prognosis focused. By that I mean, if we stop the cardiac patients, all their cardiac meds, and the diabetics patients, all their insulin, that's going to change their prognosis. They're going to go down. So Medicare changed that a few years ago, and it's more prognosis driven. So now we provide almost all medications unless it's absolutely not related. You know, Zyrtec for allergies. That's not going to change your prognosis if you don't take it. You might feel like it, but it's not going to change your prognosis, right? So we provide medications, we provide supplies that they need if they're using adult diapers, cream for their butt, if they need DME, they need a hospital bed, O2, whatever. We provide all of that, and it's paid 100% by Medicare, Medicaid, and insurance. So there's no out-of-pocket for hospice patients for everything that we do for them, and that's what I think Eric runs into. I do on the phone when I talk to families. They're like, how much is that going to cost me?
Nothing.
And it's nothing. It's no out-of-pocket. So it's a level of care that provides education and support to this family while they're losing a loved one. So we can't make it easier because your loved one's going to die, but we can help you not be afraid of the unknown. So that's kind of the hospice team and what we do.
I just had a patient, just to kind of piggyback on that really fast. We just got on board last week, or over the weekend, at hospice. I've met with this family twice before, and if I would have known before what would have took them to get on hospice to understand what was going on. They never wanted hospice. They wanted to talk to me for a 3rd time. Spoke to them, started going over everything, and then I hit the part about the DME. But the patient's been trying to qualify to get on oxygen. He says he's short of breath, has not qualified, not hit that 88% or less to qualify for oxygen. I said, well, with a hospice, we started talking. I said, if you need oxygen, he's like, wait a minute, what? But I didn't qualify. I said, no, or the daughter said, well, he doesn't qualify for oxygen. I said, no, if you need oxygen, we can provide oxygen, whether you qualify or not. If that makes you feel better and breathe better, he said, I'll take hospice.
Yep.
That was it. That was what it took. He wanted to be on oxygen, and because he says that's why he keeps coming to the hospitals for exacerbations, but his doctor, his pulmonologist, says he doesn't qualify for oxygen.
Well, it's because CMS doesn't pay for PRN oxygen, which is
Correct.
Stupid, but
Right.
That's a whole nother soapbox, right?
Yep, absolutely.
And if they would change that, you guys probably wouldn't see as many COPDers calling in, right? The main thing I want to talk to you guys about is the meds you're going to see on hospice patients when you walk in. And this is driven by a situation that I've encountered in the past, and one of our nurses recently encountered where EMS didn't understand the medicine, the medic that was there didn't understand the medicines that we put somebody on. There's no ceiling on narcotics as long as we're titrating safely and with doctor's orders. So you're going to walk in and somebody's been on hospice for a while, may be on a ton of oxycodone or a ton of fentanyl patch. You know, like we may have a 200 mic fentanyl patch on them. And if you don't understand the meds that we're dealing with and how we get to those bigger doses, it's alarming for you, because a lot of times I think you guys are trained to go to this could be an OD, let's Narcan them. And the caveat to Narcan with hospice patients is if you Narcan a cancer patient that's on a gajillion milligrams of something that we've got titrated up, now you've put them in a pain crisis that's going to be super difficult to manage. So I don't want you, I wanted to come here to talk to you guys to tell you don't automatically think Narcan. on a hospice patient. So what you're gonna see with most hospice patients is MS Contin, oxycodone, hydromorphone, morphine concentrate, fentanyl. That's mainly, I mean, and it's gonna depend, are they swallowing or not swallowing on what we're using. We do conversions from PO meds to morphine concentrate and fentanyl patches as things change and they can't swallow. And there's conversions where we're doing an equal analgesic conversion to make sure that we're not dropping them back and putting them in a pain crisis, but we're giving them the same, just in a different formulation. What you're gonna see, I touched on just a second ago, what you're gonna see in a hospice patient is when they're dying is there's minimal PO intake, change in level of consciousness, they're sleeping more, they're less interactive with their families, they're not having the urine output, they're pale, their extremities are cold, you're gonna see modeling of hands and feet. All of that for us is what we see in the very end with our patients as they change. So when you guys go in and this family's panicked and called 911, and they do, we tell them, call us first. We have nurses on call, and every hospice does, 24/7. There's a nurse on call that can go out at 3 o'clock in the morning when grandma can't breathe. They're gonna tell them what to do while they're on the way to the visit, and then they're gonna stay with them and they're gonna get meds adjusted and do whatever they have to do for as long as it takes. But families panic. Somebody comes in from out of town that hasn't been the person we're educating, that we're teaching what to do when things change. And they pick the phone up, and we're all conditioned, since we're this big, when something goes wrong, call 911, because those are our saviors, they're gonna fix everything. And so somebody panics, and you guys get out there, and they're on a tizzy, look for a DNR, ask for a DNR. I know you guys do that. I know you ask for DNRs. With most hospice patients, we encourage them to post it, but some people don't wanna look at that every day. It's a reminder. But a lot of hospice patients will have it on the foot of the bed. Some will put it on the door. Some of them leave it in a folder on. We educate them to know where that DNR is. Anybody that comes to that home should know where that DNR is. Ask them if they've got a nurse visiting, because it may be home health, but it may be hospice. So if you ask those questions and you ask if there's a nurse visiting, then you can say, is it home health? Is it hospice? And if it's hospice, then the bells and whistles should go off of, hey, let's call the hospice nurse. Because we have you guys do that. Like, a lot of times the nurses on call are getting a phone call from the medic. Hey, I'm here with your patient right now, and here's what's going on, and here's what here's what they've been given, and I see the meds here, and the hospice nurse is gonna work with you guys to get that patient comfortable. And it may be you can just get everybody calmed down and you don't have to transport, or the nurse may say, hey, I'm on my way. If you can keep the scene calm for a few minutes, I can be there in 10, 15 minutes. And the hospice nurse is gonna walk in and take over for you guys. So it's gonna free you up to go take care of somebody else that really needs you. Families are in denial sometimes. We recently had a daughter that she's like 500% in denial. Dad's on board with what's going on with the mom, but the daughter is so far in denial that she's really hard to educate. And panicked. Dad wasn't there. She panicked. She called EMS. She had 5 milligrams of morphine, which is a low dose for us, at 12 o'clock in the afternoon. At 7:30 in the evening is when she called EMS. And the first thing that they did was, oh my gosh, she's overdosed by the morphine. And that daughter latched onto it like a snapping turtle on a stick. And she's like, oh my God, hospice overdoses. So now we've gone back a bunch of steps in our education with this daughter. And it wasn't anything malicious. It was just, that's where you guys, I think your brain is trained, because there's so much narcotic abuse these days that you guys are trained to react to when there's narcotics on scene. And so the daughter was just freaking completely out. And so now that rapport that the nurse had built with her is like, you don't even know what you're doing now. You tried to overdose, and Narcan didn't work. Narcan at the hospital didn't work. So obviously wasn't the morphine 7 hours prior that was the problem. The lady was just dying, and the daughter wasn't in a good place with that. So that's why I said, just don't automatically think Narcan, especially if you can extract the information from them that they're a DNR and a hospice patient. Because we don't want to put them in a pain crisis. So I guess I pretty much hit on everything that I was gonna talk about. The handouts I put in there for you guys, and I didn't wanna take up a lot of your time, I know you guys got a lot of training to do, so I called my in-service hospice in a nutshell, because that's what I was shooting for. I gave you a couple of handouts on criteria for hospice, so what we're looking at that makes somebody appropriate for hospice. So that's just a reference for you guys. I mean, I certainly don't expect for you guys to try to identify hospice patients when you're out on a call, but I wanted you to have the information so you knew what we were looking at and where we kind of step in. I know Eric wanted to talk about what he sees from the hospital end when it's like non-emergency transportation and you guys are picking somebody up, about,
If you're able to transition.
yeah, and meds.
Yeah, just really quick, sometimes we see EMS when they come up there, or for LifeLink for transport, sometimes they're hesitant to transport, like, oh, this patient's possibly actively passing, we can't transport. And most of the time, I've already had that discussion with the family, and that's their wish. A lot of times, if it's better, we want the patient to just, if they want to actually transition in life at the hospital. But when that happens, it's the family wanting that patient home. Their wish was to be at home when they passed, or to be surrounded by family. They already know that there is the possibility of passing during transport, so that's always covered. So most of the time when that does happen, it's just because that family, that is their wishes, and that's where they want to be, or where the patient wants to be and the family wants them there. Also, sometimes I've had it a couple times, what is the, I guess, the ruling, and I've never really got a
Policy and procedure,
policy and
probably.
procedure as far as medications going home with a patient on, like LifeLink, or on the truck with the patient. Is that allowed or not allowed?
What kind of medications?
So we ask the hospital to send them home with morphine and Ativan, just because the ride in the ambulance is not always comfortable for them if they're having any pain issues. Moving them from the bed to the gurney to the bed. And the hospice nurse comes in to do the start of care and they're having pain or they're having anxiety. So we ask the hospital to send them home with a few doses of morphine, and they usually send a small bottle or pre-filled syringes and then a few Ativan, so that the nurse, when she gets there, has something to be able to help
Administer if
manage
it's
those
needed. Sometimes it's not
symptoms.
needed, but it's better to have it not needed than need it
So
not
if the-
have it, in case we're trying to drive across town. It's 6 o'clock in the evening, discharge, we get out at 7 o'clock, and then we're trying to find a pharmacy if it is needed. But a lot of times, like some have said that they cannot transport it, some have said they can. It's not been a problem.
So the problem there is that the medication you're sending with the patient, the person that's taking the patient is not allowed to give that medicine. It's out of their scope of practice.
Right.
Right.
So for them to carry it would make them very uncomfortable.
Okay.
And so whether there's a policy on it, not to my knowledge.
Right.
Yeah,
So if the family's at the hospital, we try to get them to go down to Valley Pharmacy, fill it, and take it home with them.
Yes.
If there's somebody there that's gonna stay there until EMS picks them up and transports them home, that's perfect. But sometimes there's only like a caregiver and they have to go home and wait for DME to be
Right.
delivered. And the problem
And they're not expected to give it. We always
No.
educate the family
Yeah.
member on what to do with the medications. Once you receive, this is what you're gonna receive. Just when the nurse gets there, she will go over that with you. Because we try to get out there pretty quickly after they get home for the most part. So,
Yeah, and I think the discomfort with that is that they're narcotics,
Sure.
and in our line of work, a paramedic has to sign a narcotic out and carry
Gotcha.
it in their pocket.
Right.
And so the EMTs, in their mind, that's not a
It's
medicine
not.
they're allowed to have with them
Okay.
at all.
Okay.
So we just need to work on that from our end of making sure families get that. And if they're
Sure.
leaving to go home to get DME delivered or whatever, maybe we can get those filled
Absolutely.
sooner or something. So, and that's what I wanted him here to talk about those challenges.
Because I wanted to
and
learn too about what
opportunities.
the protocol is for that
Yeah.
as well.
So when I worked at LifeLink, as long as the medication was filled and was in their belongings, it would be just like I was picking a patient up and taking them to the hospital and they were bringing their drugs.
Right.
It's just that I think the expectation needs to be understood by all parties involved that that medication is not being transported to be administered.
Right.
Like,
Correct.
that is what, and a lot of times, there's like a loss of communication there.
100%.
But as long as, I know like when I was working there, if it was in their belongings,
Yeah, normally I instruct to find out who the nurse is, make sure that nurse puts that in their belongings.
yeah,
So that you guys know that's not for you to deal with or anything, that's just part of their belongings to go home with them. the stuff that's gonna be needed once we get out there to just make sure it gets home, cause like a lot of times it's like,
That's why people die anyways.
Yeah.
Yeah.
Right.
Yeah.
so a lot of times you might
Why
not.
are you going in it?
Okay,
Right.
Yeah.
right. Like I said, for the most part, most of the time, I've not had an issue, but a couple of them got, went like, oh, I can't take this. And I'm like, so what do I do? And a couple times I've said, fine, I've signed it out. I've took it and drove it to the house really fast myself,
Yeah.
just to make sure the patient was taken care of, and my nurse would have it once she has gotten out there. And a couple times it's been good because the patient got home like a Friday evening. It was a crisis trying to go into the weekend. So, but no, I can understand that.
Yeah, I think
but-
it's-
Also coming to same as Megan, I always came from like as well. The biggest thing for me for hospice patients was always, all right, this patient's going home on hospice. Is the hospice nurse going to be there?
Right.
Because I wouldn't take someone home on hospice unless the hospice nurse was there to receive the patient.
Right.
That also makes it easier transition as well.
It absolutely does. That's hard, that's sometimes hard to do
That's
because
hard to do.
after hours, I've got one nurse on call. On the weekends, I have two.
Right.
And the Valley's notorious for scheduling a 2 o'clock life link and they get
Yeah.
transported at 10 o'clock at night. So,
Right.
I can't have a nurse sitting in their driveway for 6
Yeah,
hours.
that's always our
paying
goal.
her
Like we
what
had
she
one going
gets.
home at 2 o'clock, and just like, what was it, like Monday, if we would've waited, patient was home at 2 o'clock, if we would've had that nurse over there at 2 o'clock waiting, getting everything started, that patient didn't leave till 7 o'clock.
Yeah.
Right.
So that would've been a whole afternoon where she could've seen other patients. So that's why it's hard. That's why we always try to coordinate it. Now, if the patient is on a BiPAP and has
Oh, yeah.
respiratory issues, we
The nurse is
will,
gonna be
we're
there.
gonna make sure the nurse is there.
Yeah,
We're gonna
we
have a nurse
coordinate
ready
that.
for that because there's a lot that goes in, as
Yeah.
we know with the BiPAP, the oxygen, do they know what to do about bleeding the oxygen through there's so much that goes in, making sure the mask got sent home with the patient as well. So there's a lot that comes into play, but as far as the patient is rather stable, family understands their wishes just to get them home, then if they get there, we try to get there as quickly as possible, but can't always make that happen. But
Yeah.
we are really good about getting out there within an hour, 2 hours, sometimes 3 hours, yeah.
Which even on call though with the nurses, if there's two patient care managers, me and another nurse, and if they're at a death and they can't go do a start of care, sometimes we can go relieve them at the death because they're just waiting on the funeral home to come, where they can go do that start of care. But on a BiPAP, I mean, I know we have to meet you guys there, and so that's coordination between the hospital letting us know they're leaving, because we don't want to hold you guys up. You can't sit there while you're waiting an hour for the nurse to come, and so our nurses know that they need to be there before the patient gets home. Like when you get the call they're leaving the hospital, you need to be en route to the home so that you can be there and you can let EMS do what they've got to do to get that patient situated and onto their next call.
That's why I wish I could always have life links. Every time they're picking up a patient that's hospice on with us with a BiPAP, being able to communicate to them, let me know when you're leaving. Like, cause a lot of times I'll tell the case manager and I'll tell the nurse, let me know when they get there, and it does not happen. And I'm like,
The reason why we like meds to go home with them, just the rationale behind that is at 7 or 8 o'clock at night, the only pharmacy that's open is CVS by Owen Drive. They take 4 million years to fill one prescription. They're not going to stop for a hospice patient and fill it. You're just going to be in the line of the gajillion other scripts that they need to fill. And for some reason, years ago, the North Carolina DEA or whatever, whoever, Board of Pharmacy or whatever, changed it where hospice is, as long as it says terminally ill or hospice patient on it, the doctors can fax a narcotic prescription. It doesn't have to be the original hard copy. CVS has all of a sudden decided, I'm sure they probably got burned somewhere, and corporately they won't do that anymore. So now we run into a problem of, and we're trying to get our doctors on a situation, on a program where they can prescribe so that we won't run into that. But we were running into a problem, late at night. How do we get scripts to go to a pharmacy? And then when you go to the doctor's house to pick up the script, or you meet them somewhere to get the script, now you go to CVS and you're sitting there for 4 hours waiting for them to fill it because there's no other 24-hour pharmacy in town. And during the day it's not a big deal because there's some pharmacies, and one by our office over at Robeson and Rayford Road. That pharmacist was a hospice family at one point. She will finish what she's doing and fill a hospice patient's meds. Not all the pharmacists are going to do that though. I'll sit there and stare at them and make them feel uncomfortable until they fill it and get me out of there. But anyways, I can give them the mom stinky eye, as my kids would call it. But what questions do you guys have? I threw a lot of information out. Like I said, I didn't want to hold you guys up forever. I just kind of wanted to give you an overview of hospice.
So I do have a question, and this is just like a generalized question. So for hospice patients, I've run across some that are not DNR patients. So you have hospice patients that they want everything and stuff like that. And I just was wondering, like, how do we help those patients
Right.
without hindering those patients?
So they don't have to be a DNR to be on hospice. A lot of doctors think that, and even some families think you have to have a DNR if you're gonna be on hospice. But you don't. Patients have a right to self-determination, so they don't have to have DNR. We work hard at trying to get the patient and or the family to do that. You know, some people say, I have a living will. I don't want all this stuff done, it's in my living will. Well, you know as well as I do, that's not gonna do any good for you guys. When you're out there, you need that goldenrod paper. So the social workers really work hard at that, but how do you help those people? It's like sometimes they want everything done. I mean, and it's an educational not problem, but it's a challenge for us
Yeah.
to try to educate them on what's everything mean to you. Like, what are your goals of care? Like, if it's comfort and it's quality of life, because studies have shown that if we can keep you comfortable, keep your symptoms managed, you have better quality of life. People live a few months longer on hospice. I don't know how they determine that, but that's what the studies say. But when you guys get out there and they're full code, I mean, you gotta do what you gotta do.
I try, like, if the patient, like, I guess my question is, if the patient is stable and, you know, they're going because they have a cough or, you know, they're in pain.
Something that
That-
could be managed at home.
Yeah. So I generally try to call, just to check and see like, if somebody's coming out. So do you recommend that versus?
Absolutely. If you know they're a hospice patient, absolutely get the hospice phone number, because all hospices have a nurse on call 24/7. That's a condition of participation through Medicare,
Okay.
that there's a nurse available 24/7. So absolutely, if you guys get out there on a run and it's something that's not a life-threatening emergency, we want you to call us. We want to hear from you guys so that we can collaborate with you to get that patient comfortable. And if the family's panicked and stuff, it's okay to say, you need to make a visit, because if any of you guys ever are on a run and you call Cape Fear Valley Hospice and you get, y'all need to call me, because I'm not okay with that. I want my nurses to go when they need to go. And our team is great for doing that. You don't usually get him and a Han, but it's okay to say, no, we need a nurse to come. You know, this family needs hospice here now. So it is absolutely, I would encourage you guys to collaborate with the hospice, because it's gonna free your time up if they can come and take over the situation, and then you guys can go take care of somebody that's really in need of your services versus somebody that's, you know, a little short of breath. Yeah, absolutely. I mean, and I'm sorry I didn't bring my cards. Like I said, I sneak in presentations, but Eric passed his cards out to you guys. That's our office number on there. If you have any questions whatsoever about hospice, what we do, or anything, I don't mind if you guys call me and just say, you know, hey Sharon, you were there talking to us, and I ran into this situation the other day, and could I have done something different to make this better? Call me. I mean, I'm cool with that. I mean, y'all have my cell phone number. If you want, call me in the middle of the night. Write it down. 273-6530. 910-273-6530. Call me. Send me a text. I don't care if you need me. Sharon Mathis. I'm a registered nurse and certified wound care. So